Good afternoon, everybody. My name is Terry Hudson. I'm the chair of Sheffield CCG. I'd like to welcome you all to March's governing body in public. So before we begin, we've had apologies from Zach McMurray. And if I could just confirm with Kath Tilney, please, that the meeting is quorate.
Yes, that's correct.
That's brilliant. Okay, thank you. So if I could just bring us on to declarations of interest. Does anybody at the meeting have a declaration of interest that they wish to declare at this stage? No. Okay, so I'll move us on then to questions from members of the public. So Kath, can I confirm with you if we've had any questions come in from members of the public?
Yes, Chair, we've had one question that's come in this time.
Okay.
Would you like me to give a
brief? Yeah, are you able to read the question out for us?
I haven't got the. I was going to give a summary about the question, if that's all right.
I've got a copy of the question if you'd like me to read that out. Normally, when we're in an in-person meeting, we'd usually invite a person who's got a question to address the governing body in person, but as we're live streaming, I will read the question out for this one. So this is a question from Mrs. Milsom, who is a member of Sheffield Save Our NHS. And her question to our governing body is, following the resolution below being passed at a recent Doncaster Council meeting, Sheffield Save Our NHS have decided to take this to Sheffield Council Health and Social Care Scrutiny and also to NHS Sheffield CCG. And the motion reads as follows. South Yorkshire Integrated Care Board will take responsibility for all health and care decision making from all South Yorkshire local areas in July. South Yorkshire Integrated Care Board members should, amongst others, include councillors from each local authority, representatives from Sheffield Care, Mental Health, Public Health, Community Health, Primary Care, Acute Health, carers and trade union representatives. Private sector providers of NHS funded services should not be eligible, or sorry, rather should be ineligible for South Yorkshire Integrated Care Board membership. Will Sheffield CCG support the above proposals to demonstrate there is accountability to the public, patients and staff to ensure openness and transparency in the South Yorkshire Integrated Care Board decision making, including public access to board papers and board meetings, and allow public questions? Also, we understand that CCGs have a legal duty under existing legislation, i.e. the Health and Social Care Act 2012, to involve the public in any changes to existing commissioning arrangements. Why has Sheffield CCG not consulted individuals in its area on the proposed SYB constitution, and are there any plans to do so? So that's the question. So just want to say thank you to Sharon for sending that question in to us. If I could just confirm with Kath and Jackie, our plan is to send a full written response, which we will publish on our website, and we will do that within the next 28 calendar days.
Within the next 7 days.
Within the next 7 days. There we go. I was glad I've got you there, Kath, just keeping me on track there. Otherwise, we would have been into April. Just on that question, is there anything, Jackie, Kath or Leslie, that you'd want to respond to at this stage? No. Okay. So I think it's probably just helpful at this stage, and we will detail it in our full response, that the development of the constitution for the Integrated Care Board will be a joint responsibility between 4 CCGs through the joint committee of CCGs, and that's where that will be taken publicly. And the other party that is responsible for the development of the constitution will be the designate leaders of the Integrated Care Board. So we'll bring that to the appropriate forum, and we'll make sure that we notify Mrs. Milsom of that in our response. Okay, thank you. Just before we move on, if there are any members of the public or indeed members of our staff that have got questions for the governing body, there is an address on the meeting papers on our website where you can send letters in by email, or alternatively, you can send those through to us by post, and we'll pick them up in our next governing body in public. Okay. So I'm going to take us on to item 5. So there are a few open remarks, but I'll bring those actually as items of other business at the end of the meeting. But I just want to take us straight to item 5, which is approval of the minutes from the 13th of January. So I'm going to take those. There's a paper A in your pack, and I'll take them by exception. So if you could just flag up to me whether there are any amendments or inaccuracies that you want to raise, please do so. So pages 1 and 2, pages 3 and 4, 5 and 6, 7 and 8, 9 and 10, 11 and 12, 13 and 14, 15 and 16, 17. So Chris, please.
On the bottom of page 16, the sentence isn't quite finished off, the penultimate sentence. It says that it was a massive piece of work and the primary care commissioning committee. So it just, it would have been something like, I've looked at this with due diligence at each stage or some such wording, because we, you know, as each proposal has gone through, we've looked at that. So if that can be amended, I'd appreciate it.
Thank you, Chris. We do have the live streaming recording of the last public meeting, so we can go back and clarify exactly what that sentence means. Thank you for raising that.
I hope it was sensible.
Okay, so page 17, 18 and 19, and finally page 20. Okay, thank you. I'll take those minutes from January as an accurate reflection of the last minute. And if I can now take you to item 6, which is paper B in the noting pack, which is matters arising from previous meetings. So there are a few of them on the page. I'm going to recommend that we just take open items at this stage for update. So our first update there is just around public question around vacancies and workforce. And I've got Brian Hughes. Are you able to give us any update on it at this stage?
Thank you, Chair. The position remains as was in previous updates, that we aren't currently reporting in the way that we did previously. So the action will remain live and under action.
Okay, thank you. So next item there is 98/21, and so I'm just reading the item there. So there's a question there for me and Greg Fell. I think last time we spoke, we just needed some clarity on the exact nature of the question, and that item remains open at the moment. Moving us on to item 9/22 regarding the governing body assurance framework. Sandy, could you give us an update on that item, please?
Thank you, Chair. Yes, the refresh of the Health and Equalities Plan is ongoing and will be presented back to the governing body in May, when we come back with the 22-23 operational plan, which the Health and Equalities Plan will be a part of.
Okay, thank you. On to item 10/22, just regarding month 8 performance and delivery report. There was a discussion around exploring data further, including the local data on discharge. Kath, are you able to give any update on the position for that one at this stage?
Yes, we did. We didn't quite manage to get it into this report, but we have sorted out what we're going to do. There are a number of different data sources and things we need to check, so we have it ready to go for the next report. So I think we can use that item.
Thank you very much. And on the same item there, we've got 10/22 as well. Judy Thorley, our lay member, was to discuss ambulance response times at the next Quality Assurance Committee. Has that committee taken place yet, Judy?
It has, and we had an in-depth discussion based on a report provided by a member of the quality team, but we raised further questions that are going to be taken to the ambulance quality meeting, and that will be brought back to the next quality committee, which will take place in April.
Thank you. Move us on to item 1122, which was regarding annual health checks and the need for the uptake to be increased. That was going to be taken to the Health Inequalities Group and to the Quality Assurance Committee. Lucy and Judy, could you just update where we are with that?
It's been taken forward as part of the refresh of our Health Inequalities plan, which will be done in March and April. So yeah, it's been taken forward.
Okay, thank you. We'll make a note of that and come back to that, obviously, when the next Health Inequalities report comes forward to governing body. And then finally, on item 1422 regarding the CCG closed down due diligence report, there's an item there that Director of Finance and Associate Director of Corporate Services would meet outside to ensure that the discussion at previous governing body had been captured and passed forward. So Jackie, could you give us a verbal update on that? Although I don't believe it was you that had to discuss that. I know that you have.
Yeah, so I can update that we've had confirmation subsequent to the meeting from our shared business services provider that the timetable has been revised so that we can both produce a set of accounts at the end of March and subsequently at the end of June, and still move to merge our financial ledgers post June. So I think we can close the action now that we've had that confirmation. Terry, sorry, I just did note that Greg put his hand up on the first matters arising around the EPRR arrangements and the assurance from our provider. So I don't know if you want to bring him in there.
Yeah, certainly. I apologise, Greg, that I've missed you. There's too many things on one screen, but please come in on that item.
Thanks, Chair. I couldn't find me raise hands button fast enough. So I'm broadly happy. I mean, we may want to talk about this offline, but I'm broadly happy that the arrangement is as it should be and is pretty robust. In short, NHS England and the Foundation Trusts are the Category 1 providers. The emergency response is well coordinated through that, and certainly for the course of the pandemic, the LRF strategic coordinator has been stood up, and NHS England and also YAS, because YAS has been particularly important in this, have been very regular attenders, and the FTs coordinate their assurance through that process. That has worked very, very, very well actually through the whole course of the pandemic. So I'm pretty sure that all is as it should be in that space.
Thank you very much. I think given that feedback, we'll close that item off. So if we could just make sure that's noted for closure. Thank you, Greg. Okay, I'm going to take us now to item number 7, which is our patient story. And I'd just like to welcome Sapphire Johnson, who's the head of Commissioning for Children, Young People and Maternity. And I believe we've got Kate Gleaves' name down next to that as well, but I'm not sure if I can see Kate. So if you are here, welcome. Otherwise, Sapphire, do you want to introduce the story, please?
Will do. Thank you very much, Chair. So we've brought the patient story today, this particular story, because we had our local area re-inspection looking at how we support children and young people with special educational needs and disabilities, what you might also know as SEND, 2 weeks ago. During that inspection, the inspectors agreed with our self-evaluation that we have made good progress in some areas, but we know there's still a long way to go. And there's lots of work we still need to do to make sure that children, young people and families get the support that they need. So this story today is a really small example of one family's experiences and gives you an idea of some of the challenges that still remain in our system, but also shows how by taking a person-centered, compassionate approach, we can really make a difference to people's lives. It also shows some of the wonderful work that Michelle, who is our designated clinical officer for SEND, does with families, and what a valuable member of the team she is. This is just one of many examples where her contribution has changed a family's experience for the better. So I'm going to hand over to her to tell you a bit more.
Thank you, and welcome, Michelle.
Hi. Can you all hear me, by the way, because I have an issue with Zoom on my laptop? Oh, brilliant. Okay. So my name's Michelle Racy. I'm the designated clinical officer for SEND. I have within my portfolio a statutory duty to ensure that children are reasonably supported where there are health needs to ensure access to school. This work is usually applied at a strategic level. To get to the strategic, I need to understand the challenges of some very specific issues relating to the city's children so I can ensure the reach is wide and diverse. I became involved with Sunny 2.5 years ago via my team leader role for Children's Continuing Care, and I continue to support Sunny in my role as DCO. We applied a very specific provision of support to Sunny with the view of increasing the availability of what works using a very personalised approach. Teresa is Sunny's mum and the biggest advocate for Sunny, and we were able to use that relationship and embrace that relationship to place at the centre of everything we've made available to Sunny. So here is Teresa.
Sapphire, I don't know whether you want to reshare that with the audio button ticked. It's just quiet at the moment.
Sorry, how do I do that? Is that on the Zoom?
Yes, so when you click on your share screen, just on the bottom, there's a button that little tick box for share sound as well. So if you tick that and then share your website.
Thank you very much.
He's an absolutely delightful child. He brings joy to everyone who meets him. He's got a passion for drama, innovation, animals, nature, and most importantly, music, which is part of everything that he does. Sonny was born premature and spent time in ICU, and despite a challenging start for him, he's a confident, brave little boy. At the age of 2.5, he received a diagnosis of complex speech and language differences and various muscle disorders as well. Lacks hypermuscle, hypertonia, and he's got recognised sensory processing discrimination modulation conditions, and he's autistic. Sonny's family and those around him, including the clinical team, was very confident in their recommendations in relation to what therapies and educational adjustments he would require in order to meet his education and healthcare needs. And that included a range of therapies such as speech and language, occupational therapy, hydrotherapy, music, sensory integration and physio. Despite those clinical professionals fighting continuously for funding to ensure that they could deliver the therapies, it was never approved. As a result, we as a family had to fund absolutely everything, including education-wise, and one-to-one to support those needs. Equally, and which was really unfortunate, was the family was forced to undertake legal SEND tribunal proceedings and seek independent reports in order to improve quality of life and ensure that duties were upheld. Despite the whole process, which cost an enormous amount of money, not to mention the stress that the whole family had to go through, funding was still never released, and as a result, the education was uncertain and further legal proceedings was then having to begin. The impact of such on a family is difficult to comprehend unless you are forced into such practice. Sonny was then referred to Michelle at the Sheffield CCG, and immediately Michelle and the team upheld their clinical, legal, ethical and moral duties. Most importantly, they worked in partnership and collaboration with myself, those who know Sonny best, and they created a bespoke and groundbreaking package. This was implemented, and person-centred care was at the forefront of all of that. As a team, we've actively found ways to seek Sonny's preferences, which has been really important, is to make sure that he has a voice in all of this. In turn, he's actively respected and valued, and as part of our team, we actively seek to find his voice in various ways that work for him. Michelle highly respects and seeks parent partnership and takes a holistic care approach. And it's truly been life-changing for Sonny and the whole of his family, and also the education provider. Wherever training was required, this was recognised, packages was put into place. And as a result of the Sheffield CCG input, and in particular, Michelle's approach and care, he is absolutely thriving in his educational provision. His whole life, including through his therapies. Effectively meeting their needs requires an individualised, accountable and dedicated approach, which is continually reviewed and adapted, and this is indeed something that Michelle and the whole team are working towards. Indeed, like anything, we continue to work and thrive for better, and we're working to strengthen that package and make adjustments where it's required. But this really does highlight Michelle's continuous passion for the SEND and healthcare sector. Most importantly, it highlights how vital it is to take responsibility to ensure individual needs are met and improve quality of life.
Michelle, do you want to just sum up?
Yep. Just make sure I'm off. Yep. Okay. So we turn the HCP on its head, really, because my belief is that unless you get the health parts of a child's needs right, it's really difficult to enable them to access a level of education that enables them to reach their potential. And he now receives a very bespoke package where his needs can be met across a 24/7 period. So Sonny struggles with sleep, and actually really early on in the morning, when usually schools aren't open, they're not able to access education that right way. He does have the support to enable him to access a level of education. So we've really identified what works for him and been able to really put that in place in regards to his very, very specific needs. So yeah, I'm really proud to say that we've moved him on massively. He can now put his arm through his coat, which was really quite tricky for him to do. And even those little things for Sonny is so big for us as his team. So yeah, it's just amazing. We are trying to move that on for a lot of other children in terms of using this approach. It is tricky, but we are managing to do it. And it's a testament to all of the team that works with Sonny. They've just been amazing, understanding his very specific needs. So yeah, if we can do it for one, we can do it for many. That's my motto.
Thank you. That's us done. Thanks, Chair.
Thank you, Sapphire. Thank you, Michelle. Just immediate reflections, just on Sonny's mum's feedback there, just about the degree of person-centred care that was being offered, and that does seem like a very different story to one that we may have heard several years back. So I think it's sort of testament to the work of individuals, but I think it's also a testament to the strengthening of the relationships with our colleagues in the local authority who do so much with SEND. And we look forward to hearing back from CQC on the progress that we've made. So thank you both for joining. Just before we move on, does anybody have any comments or questions for Sapphire or Michelle? Nope, you've escaped lightly this time. So thank you, Sapphire. Thank you, Michelle, for joining us.
Thank you very much.
And we look forward to hearing more stories of that kind in the future. Thank you.
Thank you.
Okay, I'll take us now on to item 8, which is paper C in your noting pack, which is an update on the development of financial plan for the 22-23 period and approval of initial budgets for the period from April to June 2022, just recognising that's out of sync with the usual financial planning regime. So I'm going to hand over to Jackie Mills to take us through that. But just before we do that, Jackie, as always, a very well written paper, and I think a governing body here would just want to acknowledge the high level of complexity that you're having to deal with to get these plans through. So thank you.
Thank you, Terry. And I'm not quite sure how to follow the previous item, which obviously was really positive, and this story is perhaps less so, but I will make a try. As you have read in the paper, that the National Planning Guidance was issued late in December, setting out priorities for the NHS for 22-23, and that included draft system allocation. So there are just a number of points that I wanted to pull out from the paper, because it covers quite a few things in that paper. So the South Yorkshire and Bassett Law ICS Director of Finance has issued draft financial envelopes to individual organisations for the full year, to all the organisations within the ICS footprint, but excluding Bassett Law, because whilst it's now been confirmed that Bassett Law will remain within the South Yorkshire and Bassett Law system up to the end of June, the draft system envelopes excluded Bassett Law. So the financial planning has continued to exclude Bassett Law. They are, for these purposes, treated within the Nottingham and Nottinghamshire system. So we received draft financial envelopes just over 2 weeks ago, and it has been quite a intense period of time to be able to unpick all of those. There is such a high degree of complexity that we've had to go through to unravel previous block arrangements and move them back towards a more population-based footing, and has thrown up a significant number of queries and differences of treatment that we've had to work through. As noted in the paper, there was a deadline of noon today to submit our draft financial plan. I can confirm that we have met that deadline, but it's fair to say there are a number of issues that still need to be worked through before I can bring back to the governing body a final plan. As outlined in the paper, there are some quite challenging times ahead. We will have a reduction in the level of funding available to us as a result of cessation of a number of funding streams that we had access to in 2021-22. So that includes the fact that hospital discharge funding will cease at the end of March, at the end of this month. The COVID funding provided by Treasury will reduce by 53%. There are increased efficiency requirements on all systems, and there has been an introduction of what they term a convergence adjustment, which in effect is an additional differential efficiency applied to systems depending on how far over their recurrent allocations they currently are. So I've agreed with Terry that I'll just provide some further information in the private session of governing body later this afternoon. The delay of the establishment of the ICB to the 1st of July means that the CCG will continue to be statutorily accountable for expenditure for the first 3 months of the year. The way that we're dealing with that is that we will be asked to produce a plan for the whole year, as if the CCG was continuing, but at the end of those 3 months, the CCG will receive a final allocation that's equal to our expenditure incurred. So statutorily for this governing body, I suppose I can confirm that we will have a balanced plan, because whatever we have spent, we will get resource limit cover for. However, the balance of the funding, the balance of the 12 months funding that's in the plan will transfer to the ICB on the 1st of July. So in effect, whatever is left for the remaining 9 months is what the ICB will have to manage with it. What I've done in the paper is I have set out a set of budgets for those 3 months, recognising that our prime financial policies require that the governing body signs off a plan ahead of the start of the financial year. So in subject to agreement at this meeting, approving that plan allows us to commit to expenditure from the 1st of April. The budgets in there are underpinned by quite a detailed financial model, which draws on actual and historic financial and operating data, plus assumptions around impacts on the expenditure for the coming 12 months. And as I've said, an updated financial plan will be submitted to the governing body once we've got final confirmation of allocations, and a number of those issues I've referred to have been concluded. So what I'm asking for is, in light of all that level of uncertainty, that we approve a budget for the first 3 months of the year, in order that we can legally and safely commit expenditure from the 1st of April.
Okay, thank you. Are there any questions or comments for Jackie, please? No, so no hands going up. Jackie, may I ask a a question. So just recognising that this governing body's got the statutory responsibility for the first 3 months of the financial year, or is it the first 4? It's the first quarter anyway, the first 3 months of that financial year. And there's an assumption that whatever we spend, we will end up with a balanced plan, as you've discussed there. To what extent are we working with our partners in system, just to make sure that either a system plan doesn't unpick everything that we've done in our CCG plan, and likewise, we don't spend our entire annual allocation in the first 3 months and leave the system with nothing?
Yeah, exactly. So I think the purpose of producing a 12-month plan as if the CCG was continuing is in recognition that that's our responsibility to show how we can contribute to a balanced system plan. As I've noted, there are significant issues to be overcome in being able to deliver a balanced system plan, and at the moment our system is not looking like it will submit a balanced system plan, but there's still a significant amount of triangulation we need to do to be able to really get under where we're likely to land that. And notwithstanding the statutory responsibility of this governing body, we know that there are things that we want to make progress on for the Sheffield population. So it's really important we take responsibility for that full year plan and not just the 3 months that we'll be statutorily accountable. We are working really closely with our fellow CCGs within South Yorkshire just to compare and contrast and test our assumptions and make sure that we've had proper scrutiny. There is a session that's been set up for next week to do that kind of peer review and testing out some of the assumptions, and also looking at some of the distribution of resources and where that sits and whether there is any unintended consequences in that, because obviously we've set out both as an individual CCG but across South Yorkshire some of our key strategic aims. And we need to make sure that we can make progress on those and still deliver a safe and sustainable financial position. So there's a significant amount of work still to be done to be able to get to a position where we feel comfortable to be able to say that, which is why I want to just give a bit more information in private session, just so that members of the governing body are clear about some of those risks and how we're trying to tackle those.
Okay, thank you, Jackie. Anthea, your hand went up and went back down.
You asked my question, but in a better way.
I apologise for that, but at least the question was asked, so thank you. So any further questions or comments there? No. Are we happy to approve the plan as set out in that document? Okay, lots of nods, no objections. Thank you, Jackie. It's back over to you again now for item 9, which is the month 10 finance report. That's paper D in the noting pack.
Yeah, so and again, it's the tale of ongoing short-term plans that we've had. So I'll remind governing body that you approved a revised financial plan for 21-22 on the 4th of November. And that was the third iteration of a financial plan for 21-22, recognising we've had to deal with changing financial arrangements that have been in place over the course of the year. So that full year plan, revised full year plan, was designed to deliver a break-even in-year position. So the cumulative surplus that we had at the beginning of the financial year of 21.9 million, we are expected to maintain to the end of the financial year. By the end of January, we were showing a surplus of 18.7 million, which was slightly higher than our planned surplus at that point. But that was predicated on receipt of £5.2 million of additional allocations. I'm pleased to report that the forecast position is in line with the overall plan to deliver the cumulative surplus. That still assumes that we would receive 10.3 million of additional allocations, including 6 million of hospital discharge funding, 2.4 million of winter access funding for primary care, and a further 1.9 million for additional roles reimbursement scheme. So there's quite a lot of additional allocations that we've been receiving in addition to our current allocation, which, as I've said, when we're looking at the plan going forward, won't be available. A number of those won't be available to us in future years. The key point I just want to draw out is that given the time of year, obviously we've got less than 1 month remaining to the end of the financial year. We've got reducing financial risks and sufficient mitigations have assessed that allows us to put our RAG rating of achieving the control total as green. So barring any significant changes or things coming out of the woodwork before the end of the financial year, I am confident that we can deliver our required financial position.
Thank you, Jackie. Any questions or comments on the month 10 finance report? Nope. So thank you, Jackie. I'll move us then on to the next agenda item, item number 10, which is month 10 performance and delivery report. Paper E in your noting pack, and over to Kath, please.
Thank you, Chair. I noticed that Lee had her hand up.
Oh, I apologise, Lee, if I missed your hand up there.
I did. Sorry, I couldn't find the button fast enough, and really it was just to acknowledge, as I'm sure we all do anyway, but it's worth saying publicly, thank you, Jackie. I mean, just to hear you say we're coming to the end of the financial year and we're on target, given the level of uncertainty and just uncertainty really, it's just amazing. So thank you very much to you and your team for all you've done. You're wizards.
Fantastic.
Thank you, Lee. Okay, right, I'll hand over to Kath again. Thanks.
Thanks, Sarah. So performance and delivery report. So the purpose of this report is to provide information regarding the key performance measures of our providers and also our staff views and experiences updates on COVID. More recently, we've added in progress on the operational plan for the remainder of this financial year. So as usual, I'm going to assume that everybody's read the report, and I'm just going to highlight a couple of the key points. So the first area is to highlight is around performance against our constitution measures. And for a long time now, national reporting has been paused because of the COVID pandemic, but we're now starting to see there are a few measures that are coming back and are being re-established. One of those being reporting on mixed sex accommodation, and that's provided in the dashboard. We see the impact of Omicron on the January performance, unsurprisingly, and the position remains largely the same as it was when I presented back in January. And in fact, in some cases, we have seen performance worsen a bit, unfortunately. But I would hope, and we expect that in the next report that I present in May, that things will start turning a bit of a corner and starting to improve. Linked to this, my second area is looking at performance against the operational plan. So at the last governing body, we showed what the plan was for the remainder of the year. So it's just covering the last 2 months of the year, and we now have some activity and performance against that plan. I've got a bit of a theme here of the impact of Omicron, because that comes into this as well. So the plan did not include Omicron in it, and so therefore the clearance of some of these longer waiters, people that have been waiting for operations and for treatment, hasn't progressed as quickly as we'd have hoped it to have done. But again, we'd hope that starts to show through in future reports. We've got planning a bit later on the agenda, so we'll pick that up in more detail then. And then the final area that I wanted to cover was around workforce. So we've got a bit more information than we've had previously on workforce and a bit more detail on things. We've seen sickness absence rates increase over the last couple of months, and again, coming back to Omicron, the reasons for sickness predominantly have been, the highest one has been linked to stress and anxiety, and we've had in the recent months an increase in staff that have been off sick with COVID. That element of it we'd hope to have come down quite quickly. We recognise, as everyone has been struggling during this period, that it's really important that we put a big emphasis on well-being of our staff, and there's a lot of things that we're doing there, and I've shared quite a lot of them previously, and we continue to work very hard at that. The reports shows how quickly things move on, because the reports, when this was written not that long ago, talks about lifting of restrictions associated with the reintroduction of Plan A, and obviously we've moved on from that now, and we've had more restrictions lifted. The discussions we're at now is about helping to get more staff back into the office and get those connections, which should help people. So at the next governing body, I'll be able to update on that. So those were the main things I wanted to highlight. Thank you. Any questions?
Thank you, Kath. Any questions, any comments? Greg, please.
Thanks, Kath. Clear report. Two quick thought. Well, one long thought, one quick thought. One, Omicron. Sadly, I didn't protect Sheffield from the Omicron wave. It looks like it is receding. I think it's not going to recede as fast as any of us want. We're going to have a high baseline for quite some time, and that is going to impact on the rest of NHS and care activity. And I'm not sure where the planning for that sits. But I would encourage someone somewhere within NHS and social care, whether that's Sheffield or South Yorkshire, to be thinking through the epidemiological scenarios going forward, because it is going to have a long-lasting impact on the sort of the residual capacity. Just the epidemiology, now there are zero restrictions, the epidemiology is going to be quite high for quite some time, declining slowly, but very, very slowly. I don't think we'll see further waves this side of summer into early autumn. I don't know what will happen into next autumn, and I reserve the right to change all of that should a new variant emerge that causes us bother, and who knows when that might happen. But some planning does need to happen for that somewhere. Second, more positively, flu. I clocked that you'd mentioned flu and performance on flu vaccine there. Vaccination coverage is really high again for the second year running, and for the second year running, what's flu? There is almost zero hospitalization for flu, and that's genuinely astounding for the second year running. Whether or not we can keep that for subsequent years remains to be seen, but that's a genuinely astounding piece of work done by lots and lots and lots of people. Not just vaccination, but lots of other stuff, and I think it's worth reflecting on some of that. I'll stop there.
Thank you, Greg. Mark Gamsu, please.
Yeah, thank you, Mark Gamsu, lay member on the Clinical Commissioning Group. Kath, I might have got this wrong, but I thought usually in this report, and it usually comes in after the staff health check, there was some information on where we were with update around the various NHS trusts in terms of capturing information with regard to things like ethnic monitoring. And because I remember it because the table was unfortunately, I mean, there was quite a lot of red in it, but I know it was a piece of work that we're on with. Am I wrong in thinking that that was usually part of this report? Because I didn't spot it in this one.
Yeah, it's not something we've had in every report. We bring it in every so often. So we do like a stock check every so often and see how things are, because it's not something that changes on a monthly basis necessarily. So we don't keep bringing it in. Okay, so it will be back. It'll be back. That's good, because particularly given the NHS Observatory paper that's come out in the last report that's come out in the last month or so, which highlights the importance of issues around, or the fact that we need to go much further in terms of being better at data gathering. It's an important area. Yeah.
Thanks, Mark, for flagging that one, because it was one of the things I'd noticed this month that it wasn't there. And in particular, just having been in our Sheffield Health and Care Partnership Board last week or the week before, hearing some of our providers saying that their data collection is really, really good on ethnicity in particular, but on wider protected characteristics. Hopefully, Kath, we should be able to get some more robust data for future reports if that's the case. Thank you. Amir, please.
Yes, thank you, Kath. Very clear report. Just an observation on number 7, workforce. On top of the sickness rate, certainly across central locality, and I think probably across the whole of Sheffield, there are huge problems with attracting staff. So many people have left, receptionists and practice nurses in particular. And so the effect of any sickness is really teetering. I'm not sure whether this is across the board or just in primary care, and whether this should be noted in this kind of report or not, because it does come down to resilience. I'm sorry, I didn't introduce myself, Amir Afzal, GP.
Thank you, Amir. So, Kath, do you want to respond on that one? I've got a view as well.
Yeah, this section is about CCG staff sickness, so it's not specifically about workforce. In more generally across the patch, that would probably be dealt with. I mean, it could be a section that's added to this report potentially, but at the moment we haven't got that in there, and we've probably picked up on it at other points. But we could add that in potentially.
Yeah, so I agree with that, Kath. We could look at broad workforce. We might want to widen that beyond primary care staff. It may be to secondary care, social care staff. It does give us a early warning indicator of what's happening in our system. Alternatively, if we wanted to focus on primary care, it may be better for that to go through the Primary Care Commissioning Committee and then be escalated up to governing body for further information. Lee, please.
Hi, yes, Kath, thanks again for this report. It's always makes really interesting reading and raises more questions, I think, sometimes than we have time for. So just from the point of view of the workload, just looking at national data, it is worth saying, isn't it, that Sheffield does compare favourably with other core cities in terms of the waiting times, even though if you're on that waiting list, that sort of is irrelevant, really, isn't it? But it's worth noting that. Yes. I also noticed in your report that in terms of the waiting list initiatives and catch-up programmes, people are looking at those at greatest risk of harm from delayed treatment is how I understood it. And I just wondered if we know whether inequalities is taken into account in terms of people from areas which are more economically deprived or from poverty, the risk of delayed treatment is greater, and that in itself is a risk factor. So whether, I know there was talk originally about that being considered, so just where we've gone with that. I won't talk about staff absences, I was going to, but we've sort of touched on that. But I would say about the staff sickness, you did highlight that in your report as well, and I noticed that it is the major cause of people being off. I think it would be even higher if you and your team weren't doing all that you are to support staff. And I think that people, certainly when I speak to people, working within CCG, they do feel very well supported, and it does feel very family-like, actually, which is really helpful. But nonetheless, I think those figures just remind us that people are working in really stressful situations and stressful jobs, and the importance of that support. And so my point is that we've got to really ensure that we take that forward into the new organisation, because it's really key in terms of keeping people well. We know that stress is dangerous for people.
Thank you, Lee. Kath, do you want to respond on any of those points there?
Second point, I can respond on. Completely agree with you, and we'll do everything we can to take that through into working CICB. The first point around inequalities, I don't know if Sandy, if that's one that you can answer.
Yeah, I'm happy to. Thank you. Sandy Buchan, Director of Commission Development. So as part of the planning guidance national requirements that we'll be submitting next week for the draft, which Jenny Milner will be presenting later on in the meeting, health inequalities is absolutely a key part of that whole submission and plans for 22-23, not just in terms of a citywide plan, in terms of all the partners coming together to look at how we can help reduce the impact of health inequalities, well, the impact that COVID has had on health inequalities, but also each organisation is looking at their waiting list and the backlog, and looking specifically at splitting. They're looking at the figures broken down by deprivation and ethnicity to see if there is any discrepancy or difference in terms of waiting lists and waiting standards as part of the health inequalities work. So there's a whole raft of work going on that will be detailed within the submission and the plans. So that's something that will be coming, and like I said, we'll talk a bit later on about more detail, Lee.
Thank you, that's really helpful. And I just remembered that I didn't introduce myself. So I'm Lee Salisbury, Citywide GP on the governing body. And thank you to Kath and Sandy.
Okay, thank you. I'll take us now then to item 11, Patient Safety, Quality and Experience Report. That's paper F in the paper bundle. And I'm going to hand over to Alan Windle, Chief Nurse.
Thank you, Chair, and thank you for announcing me, because I would have forgotten also. I'll take some key points through the report, Chair, and members, and then obviously I'm sure there will be availability for questions. I'm going to start with overview about the current CQC position within Sheffield. CQC have announced that they'll be undertaking some unannounced focus visits to primary care based on triangulation of data that relates to the public raising concerns around access, and will be triangulated with high A&E attendance complaints and the patient service. So there will be selected practices across Sheffield that will shortly be commencing those CQC visits. I think I have previously reported to governing body, but I'll just highlight that the Sheffield Children's Hospital Trust received their CQC report a little while ago now, with a good outcome, but recognising additional work and improvement work within CAM services. Sheffield Health and Social Care Trust have also received their updated feedback of a re-inspection of their services, and I'm really pleased to report that all inadequates have now been removed. So while the overall outcome had moved from inadequate to requires improvement, there was still some inadequates for inpatient services, and have totally moved to requires improvement now. And as governing body is aware, we have been on a sustained pathway of enhanced oversight with CQC, NHS England and the CCG, and currently an exit plan of that oversight and additional scrutiny is being developed to step back to allow the trust now to continue its improvement programme, and the CCG will be key part of that through its quality review meetings. And finally, from a Sheffield Teaching Hospital perspective, we remain in scrutiny for the previous maternity service outcome, and awaiting the revised inspection for inpatient services wider than maternity, and for the well-led inspection that is anticipated roughly to be in the next few days. We're still waiting for the official announcement of the publication date from CQC for that, Chair. Serious incident reporting across the patch continues. I think we continue to look at the learning aspects of incidents that are reported across Sheffield and the city. Historically, we've had very few from either primary care or our independent providers such as care homes, and there is a national change into incident reporting through the through NHS England and the NQB board. That is slightly delayed at the moment, but we continue to support that learning from all providers as a CCG. There has been some soft intelligence that has come to us from parties across the patch within relation to some incidents that may have not been reported in providers, and we're currently working with those providers just on assurance of not simply just the reporting, it's an investigation, which we're assured that investigations are taking place. It's ensuring that there's wider learning spread across both Sheffield that we can maximise. So we continue to support that progress of learning as well. And I think finally, the bit that I want to highlight as well is it's coming back to the COVID. I think it would be amiss not for me to mention COVID and vaccinations at our governing body. The consultation and the regulations regarding revoking mandatory vaccinations will come in force on the 15th of March with regards to the requirement of CQC registered individuals ensuring that workforce is vaccinated. However, I hope Greg would support this. That shouldn't deter us from continuing to promote the uptake of the vaccine in both health, social care and the public. I think that is one of the key elements, and as in the planning guidance that has just been published, the rollout of both the spring vaccine programme and a winter programme we're currently working through on planning currently, Chair. I think that's the highlights and key points from my perspective, Chair, but happy to take any questions.
Thank you, Alan. Any questions? So, Greg, I guess you probably want to come back on that point around COVID vaccination. So I'll hand over to you first.
2 points, yeah. So welcome the revocation of the condition of employment. COVID vaccinations have saved hundreds of lives, probably thousands of lives, regardless of whether or not it's a condition of employment. The medical question is, should I or shouldn't I be vaccinated? The answer is yes, overwhelmingly. And actually, the condition of employment probably didn't help with our uptake. So I think we need to handle the comms on what next very, very, very carefully. But yes is my answer to Alan's just about question to me. A quick sort of plea. I was struck by the unannounced visits to primary care and the triangulation with A&E visits. It's a really poor proxy. And I think we need to handle this carefully, because the last thing we want is more sticks to beat very, very, very pressured primary care. So I'd welcome a sort of a steer on that, how we handle that carefully and ensure that that's done in a supportive way to our colleagues in primary care who are working very, very hard. And the last thing they need is people to throw rocks at them.
Thank you, Greg. And I believe maybe I will go back to Alan on this one. A similar inspection regime was due to happen in December, I believe, and we were hurtling into the next wave of COVID, and they were thankfully paused at that time because it wasn't an appropriate time to come. But my understanding is it's supposedly a supportive visit to practices, and it won't affect their rating. But if Alan is still on the call, could you confirm that for us?
Apologies, Chair. I lost internet connection there. Can you hear me? Sorry.
We can, yes, thank you.
Really sorry of that. Yes, I did catch what you're saying. It is supposed to be supportive. However, the line is if there are clear issues, then a full inspection would take place on any provider. That's not just primary care, also, Chair.
Hey, thank you, Alan. So yeah, Greg, I agree. It's something that we probably want to be picking up with our primary care commissioning committee through our localities. So GPs on the call and the locality managers, if you can feed that back into your localities. And then finally, it may be helpful for us to flag that up at our PCN clinical director calls that we have once a fortnight. So we'll flag those up, but thank you for raising that. Judy, please. Judy Thorley. Got two Judys with hands up there.
Thanks, Chair. Yeah, Judy Thorley. I'm a lay member and chair of the Quality Committee. My point is also around the unannounced visits, and I suppose a couple of things. One, we consider this and review sort of issues with access, but then also what are some of the good practice and some of the opportunities and that are working well in some of the other practices that we've got across Sheffield, and we ensure that that's shared both at the Quality Committee and this is looked at Primary Care Commissioning Committee too. I suppose my question is, and you may not know the answer to this, Alan, but my understanding is that there's similar helpful, supportive visits happening in other parts of the country, would be one point. And my questions around normally when there is an inspection undertaken, I appreciate this is a supportive visit, the CCG would be asked for information and data, was clearly part of what the CCG's role, and certainly the Quality Committee, is that triangulation and looking helpfully at what is working, what's not working, what have we learned from some of the complaints and incidents. And I know, and Judy's probably going to raise this too, that we've had a lot of helpful concerns raised and comments from the public via Health Watch. So how and will we be asked as the CCG for any information? If not, can we provide some anyway? And can we proactively ask for a kind of pre and post summary briefing when these happen, appreciating that they're unannounced?
Yeah, so even with unannounced, the CQC do contact the CCG, myself and the quality team, in order to give them a update around the specific practice that they would be planning to visit. So while we would have an heads up potentially of where the CQC focus is, but we wouldn't be provided the dates that an unannounced inspection would take place, as you're aware, Judy. I think what I omitted to say in that discussion that I had is that the CCG is already offering kind of a mock supportive CQC support visit to practices, and there is a number of practices already in Sheffield that have taken us up on that offer. I've worked with the team to make sure that we're ensuring that we're sharing that supportive offer from the CCG pre any notification from CQC also. So I think we're absolutely supporting the proactive approach, which is including our primary care development nurses as well as an approach to practices. But we will receive also, it would be like any other inspection, Judy, in the potentially we would not receive an outcome to an inspection, whether it be a supportive or a formal visit. That would probably come through more of the provider itself to us to support them in that post-phase inspection. Does that make sense?
Yeah, I'm just wondering, my previous experience as a chief nurse was particularly around inspections within primary care, was that we requested kind of a focus group approach so that we could come together collectively, because that's the benefit in terms of the learning and, you know, improving sort of experiences around access if we can.
Yes,
so for that.
And absolutely we can do that, and we can pick that up probably through our quality assurance committee on how we would support and engage with that with our teams and CQC. Again, I don't the supportive offer that is being suggested by CQC, again, they may not all happen at the same time in Sheffield, so you know, in an attempt, but I think there's an opportunity, as I've just discussed on serious incidents, that we could share the learning from any of those early inspections for primary care.
Okay, thanks. And Judy and Alan, if you're happy to sort of pick up that approach outside of governing body and take that through quality assurance, I think it would be very helpful. Just also recognising that you link in with the PCCC, just to make sure that that's being discussed in both arenas. Okay, Judy Robinson, please.
Thank you. I'm Judy Robinson. I'm the chair of Sheffield Health Watch. Just picking up that access issue and really not wanting to wield a stick at all. There clearly is an issue. We've been working with the CCG, particularly for people who somehow don't get in the GP system. They're required to give addresses, and if they're homeless, they can't do that, or identity if they're asylum seekers. There's an issue there. So there are some issues there. I hope we could be involved, and that came about because people fed that, and organisations that work with asylum seekers or homeless people, said that is an ongoing issue. And they're some of the most vulnerable people. So I'm really glad to hear that there will be some supportive work to be done. I hope that you continue to work with us about that feedback, so it gives you that information from the ground about what experience actually is. And just to add to the CQC, they do ask Health Watch for any feedback or evidence that we've got from public responses when they're doing an inspection. So there's really is a triangulation from a number of different perspectives.
Thanks, Judy. And again, I'm going to look to Judy Thorley and Alan just to make contact with you outside to bring that rich information into the discussion and the support process. Chris Neild, please.
Yeah, Chris Neild, I'm a lay member and chair the PCCC. So I think that most of the issues about the inspections people have covered. I really welcome the support from the CCG along with the mock visit to prepare for that. But I'm also concerned about inequalities in those practices that haven't been able to recruit or have a throughput of staff, or have had to close, you know, parts of that off. So I am concerned that it's used to change for the better, really, than as has already been said. I think the other thing to Alan really is with the requirement in terms of vaccines being stopped, do you think the social care be able to recruit more staff, or has it not affected it that much?
Thanks, Chris. So the reportable figures of social care moving forward before the NHS was that in excess of 500 staff were had left social care because of the requirement, and now that that is being revoked, I think there's definitely a discussion, and discussions continue between myself, the Director of Adult Social Care, and Greg around that revoking, really, because it's going to leave us, I think, with more complex issues for those staff that have left the industry, because I think there's a trust bit for us. And so therefore I think it's not it's come at a point in time where it's helpful for the NHS in a period of time that it's come before the actually mandated to progress, that's left an issue for social care, I think. So again, but we'll work collectively together to continue to support workforce recruitment, both in health and social care as a Sheffield city, but across the South Yorkshire footprint as well.
Yeah, and obviously totally support the encouragement for vaccinations. And thanks, Alan, for the paper.
Thank you, Chris. So in the interest of time, if we could just take new comments and new questions, I'm going to take them together. So we'll take the question or comment from Ben, and then Alan, and then Marion, and then we'll let Alan respond to the two together, if that's okay.
Yeah, I'll just make the one point I had a few, but it was just around, I noticed the behavioural science piece around breast screening. And it was just, it was a bit of a question about how and what way the behavioural science has been involved, but it's also just a little bit of a kind of just a question for anything that involves behavioural science in the future, is that there's often a real tension between kind of the objective of a particular piece of communication to get a patient to do something that we want, like get screened. And as a CCG, we're often just wanting that, you know, we look at numbers and that matters, doesn't it? But that's often in tension with shared decision-making and person-centered care, because of, you know, the video, if it was very person-centered care, would be saying like, these are the pros and cons, it's up to you. But of course, if they choose not to, then the numbers don't go up. So I guess it's just an awareness of how behavioral science, so I have had some involvement with them making a video with me, and there was a real tension there around, and I think, so I don't know if that was something that was considered during that, but I guess it's just moving forward. Behavioural science is really powerful and important, but it's also that kind of tension that we have at a CCG level of getting the numbers up versus person-centred care. Like vaccines is a great example. It's very hard to measure person-centred care, but it's easy to measure whether someone's had something done.
Thanks, Ben. I think you've just raised quite an ethical issue there in terms of how we make decisions on what we do. And I just wonder, in terms of future work, this will be picked up by the new Integrated Care Board in the Integrated Care System, and behavioural sciences will form part of the Population Health Management Unit. So I just wonder, Ben, as sort of an aside from governing body, whether you would like to come and have some discussions with that group. I think the ethics of it are important as much as the numbers, so it's really helpful feedback. Marion, please.
Yeah, just very quickly, and it's catching up on what's been said before. Marion Stone, citywide elected GP member on the board. The care home where I'm the GP had no staff to take an old chap to get his pot off twice. They sent for him again a fortnight later, and they still had no staff to send with him. So that's terrible, and that's the effect. They can't recruit, there are nobody out there. They're staffed by agency people who aren't familiar with the patient's needs, and it's going to take a long time to recover. Thank you.
Thank you, Marion. And then final point then from Nikki, please.
Thanks, Terry. I'm Nikki Normington. I'm locality manager for the north of Sheffield, also a practice manager in the north of Sheffield. I just want to touch on the, as you probably expect, touch on the unannounced visits from CQC. And I just want to go back to what Chris Neal said around my concerns around the health inequalities and the practices that deliver services in these areas that really struggle. And the majority of practices that I support in the north and the locality GP support in the north are sat within these deprived areas. They struggle with retention, they struggle with recruitment. Myself and the primary care team are working with two practices at the moment that have reached out to the CCG already because they are struggling to provide access, and it's not because they don't want to provide access, it's the circumstances surrounding it. So I welcome the visits as long as they are with the supportive visits, and I think any practice that's struggling will take any learning and any advice possible to try and improve access, but we just need to be careful because this just feels like it could widen health inequalities even further, because these are the practices that will get targeted.
Thank you, Nikki. Important point there. Okay. In the interest of time, I'll wrap that item up. So thank you to Alan for that paper, and thank you to everybody who contributed their comments and questions there. I'm going to move us now on to item 12, which is the planning update, and that includes the joint commissioning plan. And just like to welcome Jenny Milner, who has been working with Sandy on that piece of work. Is Jane joining us this afternoon? No. Okay. So over to Sandy and Jenny, please.
I'll hand over straight to Jenny, please.
Yeah, thank you. Yeah, so this is just an update at this stage on the current planning. The paper is quite detailed, so I'm not going to go through all of it. I'm mindful of your time, but I'll give you the headlines. So the planning guidance for 2022-23 was published on 24th of December. And CCG has been working very closely together with our providers and partners to create a unified place-based submission that will include the data, activity, performance, workforce projections, and a narrative that will explain how we're also going to address health inequalities, elective cancer performance recovery, as well as primary care, urgent and emergency care. An awful lot to get into on submission. The deadline for the submission to South Yorkshire and Bassett Law is the 9th of March. Subsequently, the deadline to NHS England is the 20th of April. So we've been working with our partners across the city to pull this plan together. And at the minute, the allocations, as Jackie just brought them here today, but at the time of writing this, it's all kind of drafts, so we're working a bit on what we hope the financial envelopes will be. So we're bringing it here to make you aware of it, to make you aware of the work that's been done, and to ask that you delegate the sign off to the accountable officer. And also the update, as Terry said, is the plans that we're doing around the Joint Commission intentions as well. So I won't go through all of it. There's some information in there regarding the deadlines that we've got for different parts of the plans that's got to be submitted. We're on track to achieve all of those deadlines. We've brought forward some of them so that we, as a CCG, and my partners have got some copies of the plans by the end of tomorrow. So we've got a few days to go through them and finalise the submission. What I want to kind of draw your attention to is the issues that we're aware of. So NHS England's commissioned Newton Europe to do some work, which is not an issue, just to make you aware of it's a piece of work that's happening. So one of the challenges is to align the planning that we're doing now to the work that Newton Europe will be supporting the integrated care system with from 22-23 onwards. So we've got to make sure them plans dovetail together. Workforce remains a major area of concern, and that goes much broader than just recruitment of workforce. There's also what's been alluded to throughout this governing body session is that staff are tired. Staff are exhausted. Staff have really committed this year to taking their annual leave, and anyone that's had holidays deferred for the last few years will be taking their holidays this year. So it's something that we have to factor into the planning process, is how we ensure the health and wellbeing of all workforces across the providers are able to take their time off, as well as the recruitment. So we're planning that in as part of the risk. We're not clear yet what impact the virtual ward would have. It's a new piece of, or a newer piece of work that's coming on stream, but we just need to understand what benefits that will have. So we're working through that as we go along. There's some detail around strategic funding that's still to be resolved, so that we can work it in. Jackie included, so some of the hospital discharge funding that we've had to support COVID will come to an end in March. We have a number of plans in place to mitigate the risks of that, and to ensure that we've got plans that assure us that the elective recovery plans can go ahead and won't be stopped at any point because we need to support people that's delayed in hospital beds. So we're having to dovetail that as well. And then some of the work that is also mindful of is there's a requirement in the plan to reduce the outpatient follow-ups in the acute settings and the impact that that could have on primary care. And so we're working through that, and we're having conversations with primary care colleagues as we start to reduce outpatient follow-ups in acute settings. There is probably a small risk because it'll be managed well, but there will be people that may end up going to the GP with concerns that previously would have had a secondary consultant to talk to. So we just need to factor that in and make sure primary care is cited of that as we go through. We list there what the priorities are. And as we said, a lot of this assumes that COVID's gone by April. And as Greg has said, COVID won't be completely gone by April. So we're having to manage that as well. And that, of course, has an impact on the number of people that can go through appointments because of PPE that's still got to be worn and cleansing and wiping down. So we've just got to factor in. It's not necessarily full steam ahead in everything, and how we manage that. There's information in there, so you'll be aware previous years the CCG has worked together on the commissioning intentions and joint commissioning intention process. We have a very strong focus on the tackling the health inequalities. We've used that again this year, so our teams have looked at and prioritised against how we will ensure the commissioning intentions will tackle some of the health inequalities in the areas that we know we've got, which has enabled us to then score things and prioritise in a way that factor some of that. So coming through from that, we've got some key themes that we will be taking forward. At the moment, these do feel more in a language that the CCG and health would appreciate rather than the local authority. So we are doing an additional piece of work to make sure that the joint intentions have a language that we're familiar to in social care as well as just in health. And that will be the next stage as we go forward in the planning. But there are things that we're working on together. So as we word it in here, supporting independence and the ageing well, very similar to the reablement services that we have in the local authority and hospital discharge and services and managing long-term conditions and things. So I won't list through all of them, but they're not come as any surprise. It's all of the things that we would expect to prioritising. We've also got in there the special educational needs work that we'll be continuing through next year and picking up new work streams as we get that feedback, and things around specialist weight management that will come through as a really important theme in next year that we have to do. And then the continued work on effective alternatives to hospital, making sure that we've got intermediate care, virtual wards, and that community-based diagnostic services up and running. So there's lots of stuff that we've currently been on that we'll be continuing with, but new themes coming through as well. A further piece of that, because we've put an extra check and challenge in this year, so we've got what we're calling Dragon's Den sessions, which sound a bit harsh, but it's a level of expertise where we've got some of our governing body GPs and representatives will be taking part, where the commissioners are able to come in and kind of, it's unfair to say scrutinise, but they'll be asked questions as to how they will roll out their plans, how they will demonstrate they tackle the health inequalities and deliver the outcomes that we're expecting them to achieve, and really put some check and challenge into that process. So we've got some really clear milestones and coverage of what we're expecting to be delivered as part of that. So they're happening in early March. The financial planning, I won't go through in too much detail, as Jackie's covered. It's a combined process of how we align our local CCG at place, and also the work that we're doing with the ICS Director of Finance to make sure they come together. So the final steps to creating that plan, we'll make sure we've got our milestones are expected for the go live chain, and we're really clear of what the service changes are. We'll make sure we know about the probate benefits, and we can clearly articulate what the peak performance indicators are and the outcome measures, so we can report on them back into here and future groups. We'll be clear of the risks, and I've alluded to some of them, but we'll be clear what they are and how we've mitigated them and the confidence levels that we've got with some of that. And then what we're going to do to make sure that where there is a need for additional services and business cases, that they're all planned in and brought through, and where the interdependencies are. This will all go in and feed into the project management information system in the CCG currently, so that we can track that, and it will be reported through the executive management group, the joint commissioning committee, governing body, cabinet and health and wellbeing board as always, so that we've got real clarity and line of governance going forward, and we don't lose track of that as the system starts to change and move around. So really, as it says, we're asking you to note the progress of the planning that we've done to date, and agree that we can delegate that responsibility. And one bit that I did just miss that is included in the report is that we have had a really strong process this year. We've developed a steering group of commissioners that have come together, that are going through weekly what the plans are, and we have a steering group of providers, and then we have a system of bringing that together at place. So we really have made it not just about numbers, but about conversation and dialogue and open and transparentness, so that we're all working collaboratively at place with our providers and our commissioners to make sure we're really clear on what our plan will be. Thank you.
Thank you, Jenny. Sandy, is there anything further that you want to add to that?
No, I think Jenny said majority. I think in terms of the commission intentions, the joint commissioning plan will be presented to governing body at the next public meeting, but the national submission, obviously Jenny's given the deadline with the draft one next week, and then further one in April for the national submission, which is why we're asking for the delegation of sign off for that. One thing I would like to say, though, if that's okay, Chair, is just to say a massive thank you to Jenny. Jenny is leaving the CCG at the end of this month, and as you all know, she's been high profile and done a massive amount of work on the Better Care Fund, the joint commissioning work and the planning. Going to miss her, but I just want to say a massive thank you to Jenny.
Thank you, Sandy. Jenny, are you staying until the end of the meeting?
Yes.
Yeah, so you may have spotted later on the agenda there are a few people who are leaving us, so I've got some words prepared for you. So if you don't mind staying till the end, we'll build on that. So questions and comments then, Jackie, please.
Yeah, I just wanted to draw out a few specifics in terms of financial planning and implications for us for our commissioning intentions. As I've noted in the report, I think we have to be clear there will be a large expectation for us to deliver efficiency. Jenny's pointed out, with very tired, beleaguered staff, their appetite to focus on efficiency is probably quite low, but we really need to have an emphasis on those things that can demonstrate improved efficiency, and the more we can get proper QIP, so ones that improve quality and innovation, prevention and productivity will be the absolute things that we will be looking for. There is something around our governance and how we assure ourselves. We had quite a strong governance around performance managing our QIP programme, that we need to consider how we take that forward. The other bit in terms of transition is where decisions are made in the future world. So in a traditional commissioner provider split, we've been really used to having commissioning intentions, reviewing the growth available to us and making decisions. In a more dispersed world, the funding is in different places, and we're already starting to hit some issues about where the governance is for where those decisions can be made. The risk is that as a set of organisations, we don't come together, but we sit and transfer risk or decision making somewhere else, and actually we need to find a way where we can collectively make the decisions so we make the right decisions for our populations, not for individual organisations. And then the last bit is we still are at risk with lots of information coming out at very short notice. The very detailed guidance on the elective recovery plans were only issued last week, and there's still lots of information and detail in that we're working through. There is a reconsultation currently going on national tariff arrangements and what that might mean. So we're still getting fed quite late information, even though we're required to submit plans in the very near future. So as I said, under the kind of main financial planning budgets, there's lots of moving parts here and a kind of significant amount of risk that we're managing in that. But I think the process that Jenny and Sandy have outlined about our real focus on the important things we want to take forward is strong. And I think we've got great people out there that will make sure that we take things forward.
Thank you, Jackie. Judy, please.
I know this is headline stuff mainly, but I wanted to ask whether there is thinking around looking at commissioning for non-traditional providers, particularly in relation to health and equality, where we know that doing things differently is often a way to achieve some real changes.
Thanks. Sandy or Jenny, are you able to come back on that one? In terms of non-traditional providers, Judy, are you talking sort of specifically around voluntary community organisations or something more broad?
Yes, or sometimes cooperatives or people with different governance structures, so not the usual players.
So, John.
Yeah, I would say, Judy, that we have explored that more this year than we have in previous years, and we continue to do so, especially with the linkages with the council. So I know that we've given a large amount of grants out to help with the winter planning and winter work this year to the voluntary and community sector. We have stronger links now with more community groups, and they're being asked to be a part of forums such as the outcomes steering board that we've got that underpins the joint commissioning plan. So there's a number of, I would say that we're evolving how we're commissioning with the council across both commissioning organisations, and we have developed that further over the last year or so. So I would say it is progressing, and it's where we want to go as well with some of that work.
I think that's really welcome, Sandy. It would be great if that was perhaps highlighted a little bit more, so that when things go to the ICB, that message goes with them.
I will absolutely do that.
Thank you.
Thanks, Judy, and a good tip for us: get the plans now and make sure our predecessors pick those up. So thank you for highlighting that. Mark, please.
Yeah, I think we want our successors to pick it up, Terry. But
yeah, thank you. Not our predecessors. Well done.
That was it. That was all I wanted to say. I just wanted to again sort of congratulate. We haven't done them yet, but I think I don't think we've tried this Dragon's Den idea of bringing in, and I think the team have been working under huge pressure and really short timelines, and I do think it's an indication of the commitment the team have. Try and get right some an approach to some long-term tricky problems that everybody struggles with. So I think actually creating an environment where there's an opportunity for a bit of critical challenge, recognizing the short timescales, I think is and again talking about legacy. I think this sort of model is one that we really want to make sure follows through and get carries through. We haven't done it yet, but nonetheless, I think the ambition is precisely right and it's pragmatic, and I welcome it.
Mark, any further questions or comments?
No.
No, thank you. So Sandy and Jenny, thank you for that. Jackie's pointed out some of the challenges and risks there, but I think one of the things that just sort of drew through that presentation, Jenny, was the positivity and the potential in the future. Certainly, there are two things that we really want to grasp and run with as we head into those future working arrangements. I think this set of commissioning intentions and the operational planning, and particularly us doing that in partnership with our colleagues in the local authority and with our provider colleagues through those work groups, it puts us in good stead to do things in a different way from day one. So thank you both. And now move us then on to the next item, which is integrating care. So that's item 13. This will be a verbal update. And I'll hand over to Leslie and then to Brian, please. Or vice versa, depending on who's giving that update. I think it might be you, Brian.
Brian's giving this update.
That's fine. And apologies for the oversight earlier. I'm Brian Hughes, Deputy Accountable Officer and Place-Based Lead. You'd think I'd know it by now that I introduced myself at the start of the meeting, not at the end. I've got 3 and a bit things to update in terms of integrating care. And it's almost like blankety blank, integrating care blank. So I'll start with the board. So the Integrated Care Board, which is in the progress of being established, and the appointments to the board are well underway, and a number of appointments have been made subject to sort of legislation passing through Parliament, which we acknowledged last time has been delayed by at least 3 months. So we are expecting establishment of the ICB from July. So a number of those appointments include David Crichton, who is going to be the Chief Medical Officer, and David is currently the Clinical Chair at Doncaster CCG. We've got Kathy Winfield, who will be the Chief Nursing Officer, and Kathy is currently the Chief Nurse at University Hospitals Derby and Burton. Christine Joy will be the Chief People's Officer, and she's currently within the ICS PMO and also undertaken a national workforce role. Will Cleary-Gray will be the Executive Director for Strategy and Partnerships, again, currently within the PMO, Project Management Office within the ICS. And Lee Outhwaite will be the Chief Financial Officer, and Lee comes from Derbyshire, that bit of the system, and has been there for a number of years. Chris Edwards has also been appointed as Executive Place Director for Rotherham and Deputy Chief Executive Officer for the ICB, and Chris is currently the Accountable Officer for Rotherham and Barnsley CCGs. The remaining Executive Place Director roles for the other 3 areas, including Sheffield, are now out to advert, and that process is expected to be concluded by the end of April. Alongside the executive appointments to the ICB, there will be lay member roles, and that process is currently underway as well. So the expectation is that the ICB will be established and will be operating in shadow form from the beginning of April, so the beginning of next month. So I'll move on to the P, which is the Integrated Care Partnership, and that's the broader church, the wider membership of constituent organisations across the Integrated S system. And we will keep repeating those because it's the B, the P and the S, I think, is the 3 component parts of how the system will operate. The Integrated Care Partnership is now sort of the process is underway of looking at the appointments into that, and also the connections in with our local authority colleagues to make sure that that partnership is representative of the communities that we serve. So I'll pause at that point with the P, and then I'll move into my more important for us local P, which is our Place partnership. And within Place, we had a a really helpful and constructive session with Gavin as the Chief Executive Designate of the Integrated Care Board recently, where we took him through both how the partnership has developed over the last number of years, but also really emphasising, and I know because he said how impressed he was by the strength of the relationships, particularly around our integrated commissioning, which we've referred to throughout the course of this afternoon's conversation, both in terms of scale. So I think he was quite overcome by the size of the budget that we operate in an integrated commissioning landscape, but also the strength of those relationships and the governance that we've got surrounding our joint commissioning committee and our joint commissioning arrangements, all with an eye to, as we seek delegation from the ICB into place, how that can land in a safe space. And my personal reflection is I think he was quite impressed by the strength of those relationships, both in an integrated commissioning space with our local authority colleagues and also the partnership across Sheffield. It's also worth highlighting within those place arrangements that the healthcare partnership, there is some sort of movement within the personnel within that, where there is the retirement of the current chair of the HCP, and the director lead, Mark Tuckett, is moving on. So there are sort of some sort of emerging sort of vacancies within the healthcare partnership, which we will address collectively across the city space. So hopefully that was a bit of an education of the B, the P and the S, and we'll continue to sort of talk and update as there's movement over the coming months in those arrangements and the establishment of all of those. I'll pause at that, Chair. Thank you.
Thank you. Leslie, anything you wish to add from an integrating care perspective?
And I think Brian's picked up on it all.
Perfect. So any questions or feedback for Brian on that item? Nope. Okay, thank you. I think people will be going away and reflecting on the B's and the P's and the S's, Brian. Helpful paper there. Okay, so just move us then on to part 5 of the agenda. There are a number of reports circulated for noting in advance of this meeting. Is there anything anybody wishes to draw out from any of those papers at this stage? Chris, please.
Thank you. Just the report from the Primary Care Commissioning Committee. The main thing that ran through all our discussions was where we were at and how far we developed some of the issues, and the learning, wanted to make sure that it moved over and we weren't, well, not going backwards, but the learning from that was the best starting point, because we'd improved practice, and those things included primary care capacity and access, and some of the innovative work that Abby and the team have done around that. And also the investment work, which I mentioned earlier, in the estates. And, we've looked really carefully at that, and we're coming up to, Jackie, we're coming up to a point where there's more engagement with those communities where this is happening, because it's becoming more certain that this is going ahead, and we can engage more with the community. So did you want to say something about that, Jackie? You probably can articulate it better than me.
Yeah, no, I suppose I was just going to note that we're still awaiting the formal confirmation of Treasury approval of the business case, despite getting verbal confirmation in January. We've still not had formal communication on that, which is hampering a bit of our comms, because we need to launch the communications across the whole of the ICS at the same time. But we need to get on and have some, engagement with our Sheffield populations about the specific proposals in Sheffield. So we are just managing a bit of juggling in terms of being able to deliver the different elements on that. So I am planning to do a briefing to send around governing body members. I'm just waiting for that final confirmation before doing that.
Thanks, Jackie. That was it, Terry, Chair.
Thank you. Anything else that anybody wishes to flag up now on the reports circulated for noting? No. Okay. So I'll take us then on to item 15, which is any other items of business. I've got a couple just to note down here. So the first item that I want to flag up is sad news, and that is, as a governing body, we would like to acknowledge the sudden and untimely death of our colleague Alistair Muse. And I think as a governing body, we would want to note this and pass on our respects to his family and to his friends in these very sad times. A number of our CCG staff attended an all-staff event last week, and there were some beautiful words said at that event, some really beautiful reflections, and if any of you have anything that you wanted to add or to send on to the family, please let us know as a governing body, and we will do that. So these are our condolences as a CCG to Alistair's family. Okay, so we have some other items on the agenda. So Sandy has flagged up that Jenny Milner, one of our deputy directors, is with us on the call today. Jenny's off to pastures new in the next few weeks. I just wanted to thank Jenny for everything that she's done since coming to join us initially to look after the Better Care Fund, and then really kind of took off and built those joint commissioning arrangements with Sheffield City Council. I think, Jenny, you've been instrumental in developing some of those relationships, those shared priorities. I think you've been absolutely instrumental in helping to translate the different languages that we speak across health and social care and local government, and really helping sort of to steer and navigate us through some of those complexities. So from a personal perspective, I've very much enjoyed working with you, and I just really want to thank you for helping me navigate all of that. Certainly when I became a new chair, I think you popped down to my office in the first week and said, here's the BCF, we need to get it signed. And the detail in the briefing that you gave me was superb. And I think it's going to be big boots to fill to have somebody that knows every single line of that budget inside out on the who's who. So thank you, Jenny. Does anybody else wish to say any words for Jenny there? No, just some waving.
Yeah,
Mark.
I do.
Mark, you do.
Yeah, I think, you sort of touched on it, Chair, but I think we were very lucky. I mean, I think, Jenny, we needed somebody, as we tried to develop our relationship with the local authority, who actually, it's not just about skills and technical knowledge, but it's also about, in terms of just the approach, in terms of the personality there, that is so important. Sometimes, sadly, NHS and local government can be a bit sort of antagonistic with each other. I saw that. And I do think that you managed that really well. So as a member of the Joint Commissioning Committee, I think, you were instrumental in terms of providing that personal glue that actually helped us come together. And rightly so, in terms of addressing health and wellbeing, the two big commissioners in the city need to be working together. So thank you.
Thanks, Mark. So I'll move on to the next person on my list, which is Nikki Bates. So Nikki, this is your last governing body with us in public. And if I'm right, Nikki, I believe you're part of the original crew. You were here right from the very beginning with many of the other GPs and others that are on the call here today. So I think from us as a governing body, we will absolutely miss your contributions. I know that, having been here, you having been here from the beginning, you will have been instrumental in shaping the CCG's plans, its narrative and its vision. And in particular, I know that you're kind of one of our biggest advocates for children and young people in the CCG. And it's often a group that can get lost in big cities with specialist models. And you've been consistent, certainly in the time I've been in the governing body. You've been consistent and passionate about being that voice for children and young people. And that certainly will have made a huge difference to children and young people in Sheffield and indeed beyond as those services have been shaped. So Nikki, I believe you will be retiring from the NHS at this point. So I think we are all wishing you a very happy retirement. Don't get into too much mischief and make sure that you spend that time doing lots of things that bring you joy.
Thank you, Terry. Thank you very much.
And are there any words that you want to say, Nikki, or anybody else?
Well, I have loved my my time with the CCG. I've met some really interesting and amazing people. The staff are the most important thing. It's been a bit of a roller coaster, and it continues to be a roller coaster as far as I can see from the papers. But I'm really pleased that the children are high on the agenda of the new organisation going forward and the best start in life, and I think that's really important. And I'm pleased to be continuing as a public governor at the Children's Hospital.
Thank you. Okay, and last but not least, it is our accountable officer Leslie's final public governing body with us today. And Leslie, you came to join us, I believe, in the summer of 2019. And initially that was going to be for a period of 2 years. But we did twist your arm ever so slightly just to stop with us for a bit longer. And we're very grateful for that. But if we go back to 2019, I think we would all recognise that there was a lot of work to do in our organisation. We'd got a lot of things that needed to be changed in terms of how we work together as individuals, how we could be more effective, how we linked in with broader organisations, and in particular, sort of how our culture could amend to help drive that. I think your arrival, Leslie, you're a very calm individual, but behind that calmness is somebody that is a very powerful force for good. Who has really helped change our organisation. And I was struggling to think what words to write on the paper here, but I think one of the things that you've really helped us do as a CCG is restore our moral compass, to restore our curiosity, and restore our growth as an organisation, and really help us do something that has helped us to achieve some very, very good things for people that live in this city. So from me, I think it's a big thank you. First time as a chair, I couldn't really have hoped for a different accountable officer to sort of help take me through those times. And again, I think we will all miss you as our accountable officer, as that calm influence, and as a friend as well. So is there anything you want to say there, Leslie, or anything else anyone wants to add?
I think, Terry, just to thank you for those really kind words. And to thank everyone for making me so welcome when I arrived back in the spring of 2019. It's been an absolute joy, a privilege and an honour to work with everyone in the governing body, our partners in primary care and all of the team in Sheffield. It's just been lovely to work with so many talented, passionate individuals, and to see each and every one of them grow and develop over the past 2.5 years has just been wonderful. So I will certainly miss you too, but hopefully our paths will cross in the future too.
Thank you, Leslie. And we, of course, do look forward to keeping in touch and working with you as you head off to pastures new in Sheffield. So thank you. Okay, is there anything anybody else wishes to bring up at this stage? Brian, please.
Not really sure how I can follow that, but I'm going to try, because I'm going to talk about cybersecurity just for 2 minutes, if that's okay. And it's a really important bit of any other business that is just worth the governing body noting. And this is about improving cybersecurity resilience. And in light of the heightened position around the world on cybersecurity resilience, all organisations, including the NHS, have been asked to undertake a series of assurances and immediate actions on critical controls that reduce the risks of ransomware and denial of service attacks, and submit these via, which we do anyway, our data security and protection toolkit submission. Our multi-factor authentication is a really important tool in that, which you may not see, but you all do. So just trust us that that works, and that keeps us in the main pretty safe. This update this afternoon is just to provide governing body the assurance that our team are undertaking this assessment, which is required in the immediate actions, and that no specific vulnerabilities have been identified. Further actions will follow over the coming days, weeks and months, but there was an immediate ask in sort of pretty rapid time to undertake that initial assessment. And what I have been asked to do today as your CIRO is to reassure you and give that assurance that we have undertaken it and no specific vulnerabilities have been identified at this stage. Thank you.
Thank you, Brian. I'm not sure there'll be any questions to follow on there. I'm assured somebody is looking at the cybersecurity, Brian, and in terms of the multi-factor authentication, we've all got those to log on to our internal network, so thank you. Okay, any further items of any business that anybody wishes to flag up at this stage? Nope. Okay, just recognizing we've got about four and a half minutes left. So as usual in the public meeting, I think it's sometimes helpful just to hear some reflections back from governing body members about what they've heard and what they will go away and share with their teams in primary care, with their teams in the CCG, and with wider partners. So is there anything anybody wishes to reflect on? Ben, please.
This is kind of answering your question, but it's kind of also going back to Leslie. I barely know Leslie, but I've seen and heard about the impact that she has had. And I think she's one of the best leaders that this country has, honestly. It's just remarkable, in terms of culture change and the impact you have on people and the team and the city is enormous. And I guess reflection, leadership's just so important, isn't it? You can have all the technology, you can have the staff, you can have people who've got abilities, but you need leaders to unlock that, and that is what you've done.
Thank you, Ben. Jackie, please.
Sorry, it probably follows a similar theme. I suppose my reflection is around legacy. So, you know, we've talked about the legacy that Leslie, Nikki and Jenny have given us, and I suppose recognising some of the difficulties that lie ahead that we've discussed today. I think the importance of you know, giving a commitment to them as individuals and to our staff that, you know, those things don't get lost when individuals leave, that we will kind of build on and take those forward. So, you know, it's beholden on all of us, isn't it, that you know, those that remain in the system or those that choose alternative paths, that we can make sure that we, you know, follow through on the commitments that we've given.
Thank you, Jackie. And anybody else at all? Nope. Okay, so I think those were two lovely reflections. And Jackie, I think the point there on the legacy, you know, it's often argued, isn't it, that the organisations and people within and the products of the interactions that they have with others, and certainly we need to make sure that we take those positive interactions with our people forward with us as we progress in the future. I think that's probably a good point to close our meeting on. So our next public meeting is going to take place on Thursday, the 5th of May. That will be between 2 o'clock and 5 o'clock. Details of that will be confirmed on our website in due course. And we look forward to seeing you then. Bye-bye.